Okay, so we're going to talk about blood. So I just want to talk about the cells first. So in blood, you already know that we have neutrophils are the most numerous vessels in blood. So I've got neutrophils. I've also got basophils. I've got eosinophils. I have lymphocytes, and I have monocytes. So these are the types of blood cells in blood. Now, when you look at the order of these, if you can remember this saying, never let monkeys eat bananas. This actually tells you the order that they're in. Neutrophils are your most numerous, then lymphocytes, monocytes, eosinophils, and basophils. So those are the formed elements in blood. Additionally, in blood, we have thrombocytes. And so thrombocytes, as you know, they're not true cells, they're fragments of cells. You had the megakaryoblast that kind of fragmented apart, and it produced the thrombocytes, also known as platelets, that are just these traveling bags that allow for platelet plug formation. Anyway, so right here what I have is I have the vascular smooth muscle. So the vascular smooth muscle, what it does is it surrounds the blood vessel. It's kind of like this piece of paper right here. I've got this piece of paper, I roll it up. This would be like the blood vessel. My fingers would be like the vascular smooth muscle. They can vasoconstrict and they can vasodilate. And so I can control the diameter of this vessel. Well, we're going to look at hemostasis, all right? So with hemostasis, what occurs is this, is normally have all these blood cells circulating through here, and what's taking place is these endothelial cells are producing molecules like prostacyclin and molecules like nitric oxide. Now, prostacyclin and nitric oxide don't allow platelets or anything else to stick to the surface of the endothelial cell, so they're anti-aggregating agents. However, underneath the endothelial cells, you have the extracellular matrix. And so here I have this extracellular matrix that is underneath the endothelial cell. So even though things can't stick to the surface, if I were to damage these cells, the subendothelial layer is considered thrombogenic. It's actually going to form a thrombus. So what we're going to do is we're going to damage this and show you what happens in terms of hemostasis. So when I damage an endothelial cell, the first thing that's going to take place is I'm going to want to vasoconstrict this area because I don't want to bleed out into this area. So one of the things that damaged endothelial cells produce is they produce a thing called endothelium. And what endothelium will do is it will actually plug into what's called an ETA, endothelium receptor, on the vascular smooth muscle. When this happens, this smooth muscle cell, you'll see calcium channels, you'll see an entry of calcium, and as you know, I'm going to form those calcium calmodulin complexes, activate myosin light chain kinase, and then that's going to split ATP to ADP and phosphate. I'll give the phosphate to myosin, I'm going to get vasoconstriction. And the reason I'm vasoconstricting here is to prevent blood loss. All right, so now we're going to put a platelet plug right here. So here comes this thrombocyte. Now normally these thrombocytes don't stick to each other or stick to the endothelium, but this they're going to stick to. Because in the subendothelial layer, I have a molecule called von Willebrand's factor. Even though it's a W, it's a German, so it's von Willebrand's factor. Von Willebrand's factor will interact with a molecule on the surface of the thrombocyte. So the thrombocyte has a molecule on its surface called a glycoprotein, and this glycoprotein 1B molecule. When von Willebrand's factor activates the glycoprotein 1B molecule, what happens is I get a release reaction and I release ADP. ADP is adenosine diphosphate. Well, adenosine diphosphate then will plug into receptors on the thrombocyte. However, it's not just on this thrombocyte, it also acts as what's called a paracrine. So it's going to plug into receptors on adjacent thrombocytes. Now, when this takes place, I activate these COX-1, COX-2 enzymes, and I'm going to synthesize a molecule called thromboxane. And so what I'm going to do is I'm going to synthesize thromboxane A2. So thromboxane A2 is now going to be synthesized, and what thromboxane A2 does is it causes a change in the glycoprotein 2B3A receptors. So here I have these glycoprotein 2B3A receptors. Draw this over here. So glycoprotein 2B/3A receptors. Now normally these won't allow for adherence. But now that they've been activated by thromboxane A2, okay, because thromboxane A2 has acted upon this to activate these receptors, now they can cross-link with fibrinogen. So now I'm going to cross-link with fibrinogen, and now these platelets are starting to stick together. And so what I have is I have this area of primary aggregation where everything is starting to stick together. And this just continues on. And so it's a positive feedback cycle that as ADP activates thromboxane A2 activates the glycoprotein 2B3A receptors, they cross-link with fibrinogen, and I start to form a platelet plug. But this is going to be controlled also, because I'm not going to completely occlude this area, because over here what's taking place is I still have healthy endothelial cells, and healthy endothelial cells are producing nitric oxide and prostacyclin, which is not allowing it to adhere into this area. Also in plasma, I have a phosphatase that actually degrades the ADP, and so ADP doesn't continue to act on the thrombocytes. Now, initially what's going to take place is I just want to form a plug to keep from bleeding into this area. So I'm forming this platelet plug, but it's not stabilized yet. I need to stabilize it, and I need to form a blood clot. And so a blood clot is the platelet plug plus the fibrin. All right, there it goes. We just lost power and it came back on. So it's the blood clot plus the fibrin. So what I'm going to do now is I'm going to activate what's called the intrinsic cascade. So if I activate the intrinsic cascade, what I'm going to do is I'm going to convert factor 10 into factor 10A. And I can do this by activating the intrinsic. Intrinsic just means that the blood contains everything in and of itself needed to coagulate. Now this cascade, this takes about 8 to 18 minutes to actually go to the final product of the blood clot. However, because I've damaged tissue out here, I can also activate the extrinsic. And so the extrinsic can also convert factor 10 into factor 10A. A just stands for active. So this would be extrinsic, and extrinsic means it's outside of the vessel. So there's something extra I'm adding. And that something extra is called tissue factor. Tissue factor is also called tissue thromboplastin. So tissue factor, tissue thromboplastin, it's a group of chemicals that will activate these receptors. All right, once I get to factor 10A, 10A then is going to launch and activate other products. So factor 10A is going to convert what's called prothrombin, and prothrombin, I'm going to run out of room, prothrombin is going to be converted to thrombin. All right? And then once I've activated thrombin, I'll come back this way so you can see it, but once I've activated thrombin, what's going to happen is I'm going to activate fibrinogen into fibrin. All right. So now that I've activated fibrinogen into fibrin, I can go ahead and start laying down a mesh of fibrin polymers or monomers over this, and they'll form this fibrin polymer to reinforce the clot. So that is coagulation. This is a thrombus, this is a thrombus, this is the coagulation. Now, the other thing I'm going to do is thrombin is also going to activate another molecule, and I'll go ahead and actually draw it up this direction. So here's thrombin. It's activating a molecule called plasminogen. And plasminogen is converted by thrombin into a molecule called plasmin. And what plasmin is going to do is it's going to seed itself into this clot, because plasmin is actually going to degrade the clot. Okay? So just to review, we've damaged the endothelial cell. We've exposed the subendothelial layer. Glycoprotein 1b binds with the von Willebrand's factor. That activates the degranulation of ADP. ADP activates an ADP receptor. That synthesizes thromboxane A2. Thromboxane A2 activates the glycoprotein 2B3A receptor. And so now we form the platelet plug, and then we go into coagulation. This process stimulates the intrinsic and extrinsic pathway. We activate factor 10 into factor 10A, the active form. It converts prothrombin into thrombin. Thrombin converts fibrinogen into fibrin, and also plasminogen into plasmin. Plasmin breaks down the clot, because what I don't want to have happen is that when these endothelial cells start to migrate along here and start producing prostacyclin and nitric oxide again, I don't want them to dislodge that clot. So now I'm just going to give you some clinical application, because clinically you're going to be using thrombolytic agents you're going to be using antithrombic agents, and you're going to be using anticoagulants. Those are three different things. And so if I use an antithrombic agent, what I'm doing is I'm preventing thrombosis. So for example, let's say that Grandpa had a heart attack. So now he's on aspirin. And so they give him 81 milligrams of aspirin at a daily dose. Well, when he first had his heart attack, they might have actually given him 3 baby aspirin and had him chew it, because what that does is baby aspirin will go in here and it'll block the synthesis of thromboxane A2. In fact, it binds covalently to these COX-1, COX-2 enzymes, so those platelets are done. So as soon as you chew that aspirin and it blocks those COX-1 enzymes, COX-2 enzymes, you can no longer form thromboxane A2. Those platelets are done for. So it prevents the platelets from sticking together. And then, of course, when they discharge prophylactically, they'll give the 81 milligrams just as a lower dose to prevent lots of platelets from sticking together. Well, another drug they might give him is one called clopidogrel. You might know clopidogrel as Plavix, because Plavix, what it'll do is it'll actually come over here and block the ADP receptor, and so it prevents you from actually activating thromboxane A2. Another drug they might give in the hospital IV is one called integralin, because what integralin does is it blocks the glycoprotein 2B3A receptors. So those are antithrombic medications. Now, they also have anticoagulants. The ones you're probably most familiar with are things like enoxaparin or heparin, because what those do is they block these clotting factors over here. And so what they're doing is they're blocking my clotting factors here. So they're different from the antithrombotics. Another one would be Coumadin. Grandpa has AFib. With AFib, the heart, the atria just quiver, and so you can get stasis of blood in the auricles, and so you don't want to form these platelet plugs. And so what they'll do is they'll put them on Coumadin, and Coumadin decreases the clotting factors. So they're, again, anticoagulants. Let's say that you have a clot, and you want to break that clot down. Well, they used to give what's called staphylokinase and streptokinase, because those enzymes, those kinase enzymes, were actually bacterial enzymes that would convert plasminogen into plasmin, and they were called clot busters because they would actually break the clot. Well, now if you have, let's say, a central line and it's clotted off, they can use heparin in there, but they can also use TPA, which is this plasmin activator, and that'll break down the clot. So again, those are our these would be our thrombolytics, lytic to break a thrombus, and then our antithrombotic medications and our anticoagulant medications.